Bismillah Rahmani Rahim. Welcome to Monthly Journal Club. I am Professor Javed Khan from Aga Khan University, and today we have two distinguished pulmonologists from Islamabad and Rawalpindi, Professor Jawad and Dr. Sajjad Nasir. Both are going to present two interesting cases. As you know very well that this monthly journal club activity is started by BMJ group of journals, and Thorax is well recognized, one of the most prestigious international journal in respiratory medicine, which publish papers every month. And we give our two speaker a chance every month to select article and then present it to the respiratory physician. Not only people join us online, but we have most of the respiratory units in Pakistan, where we make arrangement for all the doctors, particularly respiratory medicine doctors, as well as medicine doctors, to learn from this journal club activity. And it has been a great success. And now I understand that many other specialty also wants to start a similar activity from their platform. I'm most grateful to KC Pharmaceutical for their excellent contribution, generous contribution for this educational activity. And without their support, we would not been able to organize this activity. So without any further ado, let me invite our first speaker today. First speaker is Dr. Sajjad Nasir. He is Associate Professor of Pulmonology at the Health Services Academy, Islamabad, and he works at a Maroof Hospital. And he has done his FRCP Glasgow. He is MRCP, and he has also done CCST UK. So he is well trained in pulmonology, and today he is going to talk about a paper, Nocturnal Hypoxemia in Interstitial Disease, a systemic review. So over to you, Dr. Sajjad Nasir.
Thank you very much, sir, for your kind introduction, and thank you very much to you and Chazy for giving me and to all the respiratory physicians this platform. So without wasting any further time, I will go to the article which we picked up for this journal club. As we know that BMJ is a global sort of healthcare knowledge provider, and they've got provided excellent platform worldwide for sharing the knowledge and expertise to improve the experiences, outcomes, and values. And they also had a partnership with the Royal Colleges of Physicians, and they are leading scholarly and professionally medical organizations, and they publish the latest and most relevant research. A disclaimer for my talk is with Chazy, as we all know. The topic which I picked up is the nocturnal hypoxemia in interstitial lung disease, a systemic review from December 21 journal. Brief introduction as given by Dr. Javed. For myself, I'm currently working as an associate professor in Department of Pulmonology in Health Services Academy, Islamabad. The talk would be divided into certain subgroups. We'll start with the introduction, the methods which were used by the clinical research team, the results which were finally found out, a brief discussion and a take-home message, and a conclusion from the article. As we all know, that hypoxemia is an important clinical manifestation of interstitial lung disease. And as we are aware that there can be different causes, including parenchymal lung disorder. It can be because of underlying vasculitis. It could be because of the upper airways issues which can happen with these patients. All these different issues can lead to hypoxemia, and it's an important clinical manifestation of ILD. And we are aware that patients with ILD, they are at increased risk of nocturnal hypoxemia when they are in the supine position, and also at night time when there is reduced ventilatory drive, which can happen nocturnally. Also, obstructive sleep apnea can be a very common comorbidity, which could be due to the changes in the upper airways, and that can predispose patients with ILD to obstructive sleep apnea. But however, there have been studies which show that obstructive sleep apnea can be a separate entity and common comorbidity in ILD, which can further contribute to the nocturnal hypoxemia and underlying pathophysiology. Now, hypoxemia, as we know, can be a contributing mechanism for a pulmonary hypertension, which can be an associated comorbid condition which can complicate interstitial lung disease. And there have been, again, studies which show a very strong linkage between the prognosis and as well as the pulmonary hypertension. So again, nocturnal hypoxemia can lead to hypertension, and that can also lead to worsening of the prognosis associated with interstitial lung disease. Besides affecting the mortality, it can have morbidity effects, with the daytime function being reduced because of the daytime hypoxemia in patients with chronic lung diseases. This systemic review and the meta-analysis, the aim of the study was to see that what has been the diagnostic criteria for the nocturnal hypoxemia, the epidemiology, association, what are the different management options being picked up by the different research groups, and the prognosis of nocturnal hypoxemia in ILD. The eligibility criteria of this study included all the original research publications of participants with ILD of any etiology, whether IPF or non-IPF, age more than 18 years. Clinical features of interest included diagnostic evaluation, epidemiology, associations, and prognosis. And the minimum number of participants with ILD for studies addressing the clinical features and management aspect were 10 and 5 respectively. So clinically significant nocturnal hypoxemia, as decided by the group, was defined by the individual study criteria. So the different studies which were picked up, they had picked up the different sort of criteria for nocturnal hypoxemia. So the meta-analysis group picked up all those different criteria, and they were sort of picked as it is by the meta-analysis group to define what we know about clinical significant nocturnal hypoxemia. And that was one of the outcome measures for the epidemiology as well. All the demographic, ILD disease related and health related variables in relation to nocturnal hypoxemia were included for the assessment of association between nocturnal hypoxemia and the different co-associations. And the studies were searched in Ovid Midline, MBAS, and Central Cochrane reviews. So initially, the meta-analysis group picked up about 7,328 records, which were identified through database searching. And out of 7,328, 6,095 were selected after removing the duplicates, which were present in different sort of search engines. And then finally, another 5,895 records were excluded, and finally 200 full text articles were assessed for eligibility. And out of 200, only 53 studies were included. There were about sort of extensions of the initial studies which were published later on the online journal groups, and hence the total number theoretically was 63, but in fact there were original 53 studies. 137 studies were not excluded for variable reasons, like which were not evaluating outcomes of interest for this meta-analysis. The studies didn't include any ILD, or they were having mixed diseases, or the participant numbers were inadequate, and there was insufficient data to determine study eligibility, and there was overlap population for many different reasons, which sort of helped them to finally categorize 53 studies. Out of 53 studies, all were picked on the basis of the diagnostic criteria of nocturnal hypoxemia. 11 studies were focused on epidemiology, 41 studies were focused on risk factors and associations, 6 studies were focused on prognosis, and two studies only were focused on the management of nocturnal hypoxemia in ILD. They used different statistical analysis, and the study selection was mainly done by using simple kappa studies. Data extraction was performed using a standardized data extraction of form with a data variation. The risk of bias assessment was evaluated independently by the two different authors using a modified version of the risk of bias checklist and risk assessment tools. And the disagreements between the two authors were resolved by consensus or using a third author. So they tried to reduce the bias as much as they could do for the meta-analysis. The meta-analysis was performed while using the STATA. The pooled prevalence of clinically significant nocturnal hypoxemia was calculated using the Freeman-Tukey transformation. And there were different subgroup analyses were performed according to the use of different diagnostic criteria of clinically significant nocturnal hypoxemia, ILD, different subgroups, which were sort of IPF, UIP versus mixed ILD, and the presence or absence of comorbid obstructive sleep apnea. And the post-hoc sensitivity analysis were performed to explore the heterogeneity observed in the primary analysis. So finally, as we know that 53 studies were included, total participants of the meta-analysis were 2,590. And as I said, there are different sort of parameters used for nocturnal hypoxemia, but the most frequently reported parameters were lowest oxyhemoglobin saturation, mean SpO2, percentage of total sleep time with SpO2 of less than 90%, and ODI indices. The most commonly used criteria being used was total sleep time of less than 90% and being more than 10% of the total sleep time. Other criteria were TST 90 more than 30, or one episode of desaturation duration more than 5 minutes and lowest SpO of less than 85, or both. SpO2 of less than 88 for more than 5 minutes. And ODI more than sort of 10, or TST 90 more than 20% of both. So just to sort of give a brief idea to the audience here, that there has been a wide variation of different sort of means of identifying the nocturnal hypoxemia, and hence that was, I think, one of the reasons the authors were interested to know that what can be a uniform criteria to identify people with nocturnal hypoxemia, which can have a clinical significance in future for future studies and as well as for clinical evaluation. With the results, they found out that if they are using just the general nocturnal hypoxemia, the pooled prevalence was 37%. However, if they use the criteria of total sleep time of less than 90, more than 10% of the sleep time, the pooled prevalence was 40%. So there's slight 3% increase when they're using this generic indices. And from the results, they found out that there's no significant differences in the pooled prevalences according to the ILD subtype and comorbid obstructive sleep apnea status. And because of the study heterogeneity, because of the different variables included, they were not able to do the meta-analysis of associations and prognosis. One of the common things they found, which we'll discuss in the next few slides, that the DHCO and echocardiographic features for pulmonary hypertension, they were consistently associated with nocturnal hypoxemia. So these were the different studies which were picked up, and we can see that there is a variable association of nocturnal hypoxemia in the different studies. And the final sort of pool prevalence, as we discussed, was 37%. But if you're looking for TST 90 less than 10%, the pool prevalence was about 40%. Now, in the results, the sort of important clinical findings they had was that one of the studies reported that TST 90 less more than 10%, and the maximum SpO2 desaturation was associated with new or worsening pulmonary hypertension at 12 months' time. And we all know that pulmonary hypertension is one of the prognostic markers in ILD. Similarly, nocturnal hypoxemia was associated with daytime resting and exertional oxygenation. However, the results were not clinically significant. Interestingly, there was inconsistent association of nocturnal hypoxemia with the different ILD subtypes, and that also included the severity of the ILD on the CT scans. That has no sort of association, statistical significant association between the severity of the ILD and the nocturnal hypoxemia. And similarly, there's no association, sort of consistent association between the forced vital capacity and nocturnal hypoxemia. Also, there was variable relationship of different nocturnal oxygenation parameters with the comorbid sleep apnea and apnea-hypopnea indices. However, with the multivariable analysis in most of the studies, they found out a significant association of nocturnal hypoxemia with survival. As I've mentioned, that only 2 studies out of 53, they showed these more short-term intervention studies where they provided the supplemental oxygen of 1 to 3 liters a minute, and that corrected the nocturnal hypoxemia with improved heart rate during in-lab observation. And also they found that there's increased serum antioxidant levels after 1 month of the oxygen therapy. So with the different, as I've discussed, just a graphic representation of what we discussed in the last few slides, we can see that there's a variable association of nocturnal hypoxemia between the mixed ILD and the IPF group. Overall, a clinically non-significant association between the subtypes of ILD and nocturnal hypoxemia. Similarly, with the sleep apnea, non-sleep apnea group, we can see that there is a variable association between nocturnal hypoxemia and the sleep apnea group and the non-sleep apnea group. And statistically, it was a significant association between OSA and non-OSA groups on the studies which were included in the meta-analysis. It just gives a graphic, again, presentation of what we discussed in a couple of slides before. And just to sort of highlight the important points, as we mentioned, that clinically significant nocturnal hypoxemia was associated with DLCO and also with the pulmonary hypertension. However, we can see that as far as the radiographic assessment is concerned, and as well as the forced vital capacity is concerned, there's no sort of linear association between the severity of nocturnal hypoxemia and the severity of underlying lung pathology and physiology, suggesting that there could be some other underlying parameters which contribute to the nocturnal hypoxemia in this variable groups which were studied. I'll just briefly go through, because most of the clinicians would be interested, that we know what we discussed, that nocturnal hypoxemia has an important association with the ILD, and there is a prognostic association with pulmonary hypertension. So the question is, what can be offered to the patients with nocturnal hypoxemia in ILD group? So only 2 studies were included, and they were both very sort of small studies. One of them was a case control study which recruited only 19 ILD patients, and they gave oxygen to the 19 ILD group and compared them with the healthy control, and giving in an extra sort of 1 to 3 liters significantly improved SpO2 as well as reduced heart rate during the sleep in the ILD cohort. However, there's no difference between the sleep architecture in that small group which was studied in this interventional study performed by the authors. The other study, which is 1 month RCT double-blind crossover trial, again a very small number of patients, 12 patients with TST90 of more than 10%, nocturnal supplemental oxygen of 2 liters significantly reduced the TST90% time. It improved the ODI and also HI compared with the people who were on the control group. And they also found that antioxidant levels were higher with the supplemental oxygen as compared with the medical air. So the authors found out that TST90 was associated with the disease progression in IPF and predictive of progression-free survival in both unadjusted and multivariable analysis. One of the studies also compared the ODI, and they found that 4% ODI had a direct association with mortality in both adjusted and multivariable analysis. One of the studies, which is particularly only focused on the UIP or IPF patients with a median follow-up of 12 months, they found that coexisting sleep apnea and clinically significant nocturnal hypoxemia, they were associated with increased risk of ILD disease progression and mortality. So a brief discussion of the findings we had, just to summarize, we know that nocturnal hypoxemia is a common and clinically significant feature in patients with ILD. Because of the substantial heterogeneity across the studies, which prevented the meta-analysis, we knew from this study that nocturnal hypoxemia, they are consistently associated with DLCO impairment and echocardiographic features of pulmonary hypertension. Two intervention studies showed that oxygen can improve the oxygenation and increase the antioxidant levels. And the nocturnal hypoxemia has got prognostic significance, although with variable results for different nocturnal oxygenation parameters. And the studies use different parameters like the magnitude of change in the SpO2 from awake, the frequency of desaturation, and the duration of desaturation events. Hence, I think it's an important time for respiratory physician and the researcher workers to find out that how can we clinically identify patients with significant nocturnal hypoxemia, which can benefit from the supplemental oxygen therapy. And we still don't have a standardized definition for clinically significant nocturnal hypoxemia. DLCO was strongly associated with severity of nocturnal hypoxemia, but the specific mechanism for this relationship is not known. And just a brief word about the respiratory physician interest in sleep apnea and the pulmonary hypertension. We all know that sleep apnea can sort of be a comorbidity. However, it can also limit the study of nocturnal hypoxemia in ILD by causing the dips in the oxygen saturation. And also the other side is that because of the reduced respiratory drive during the sleep and because of the rapid eye movements during sleep muscle atonia, it can lead to hypoxemia in patients with restrictive lung disease. And that can sort of confound and complicate the clinical picture. And again, that gives sort of an insight that we might be dealing with different phenotypes, which might require different management strategies depending on the individual patient needs, rather than having a blanket treatment for this particular group. Also, we know that pulmonary hypertension is an important prognostic marker. And again, because of hypoxemia, pulmonary hypertension can get worse. And at the same time, because of the pulmonary hypertension, nocturnal hypoxemia can get worse because we are sitting on the very steep curve of the oxygen hemoglobin dissociation curve, where small changes in the PO2 can result big changes in the nocturnal oxygen levels. So I would just conclude my talk from this meta-analysis that we know that nocturnal hypoxemia is common. We need to identify the way of identifying significant nocturnal hypoxemia. We knew from this meta-analysis that nocturnal hypoxemia is associated with DLCO impairment, which can be used to identify the patients which might need supplemental oxygen. And it's also associated with pulmonary hypertension, and they've got potential prognostic factor in patients in ILD. However, I think there's still a very big need to establish a consensus definition of nocturnal hypoxemia and evaluate the long-term effects of nocturnal supplemented oxygen in interstitial lung disease. Thank you very much. I'd be happy to take any questions once Sir Jawad has given his presentation. Thank you once again for giving me this opportunity.
Okay, thank you very much, Dr. Sajjad, for very clear presentation. And I think we can take question on the chat box. So I'll request all those who are attending at various chest units in Pakistan, they can request somebody to write on the chat box their question, and Dr. Sajjad will be available in the end to discuss. And so I now request our next speaker. Next speaker is Professor Major General Jawad Ansari. And I know Jawad, first time we met Jawad, you will recall, at the Birmingham Heartland Hospital when I was doing a locum there and you were receiving training. And we had one excellent chest physician there, Sherwood Burge. And one of the style of Sherwood Burge was that he always used to wear socks with different color. And I asked Jawad, what is this style? One green colored socks and other is red colored sock. And he was the world authority on occupational lung disease. And I learned a lot about occupational lung disease. So Jawad is the current president of Pakistan Chest Society. He has is the former dean and of Army Medical College, and he's also done a lot of good work for the Pakistan Chess Society. He has also received Hilal-e-Imtiaz, one of the few prestigious awards that our doctors community get from time to time. So over to you, Jawad. And Jawad is going to also talk something related to COVID. And Jawad, I request you to take over mic. Thank you.
Bismillah ar-Rahman ar-Rahim. Thank you, Professor Javed Khan, for your kind words and reminding me many good things what we shared in Birmingham. And I'm also grateful to Dr. Sajjad, who made a very wonderful presentation. I'm sure that in next half an hour or so, with my presentation on the COVID, I will be learning a lot from the presentation itself. And of course, others who are viewers will also learn something from this. I'm very grateful to Chedi Pharmaceutical that they have been very kind and courteous that provided this opportunity for this interactive forum. As you know, that Thorax is a very popular journal among all the chest physicians all over the world. It is one of the 70 journals which are published by BMJ and in the consultation with many scholarly bodies. I have picked up this state-of-art review article from the volume 77 that was published in this month of 2022. This is respiratory epithelial cell responses to SARS-CoV-2 in COVID-19. The topic appears to be very complicated, but I will try to make it as simple as possible. This is a very good article written by authors. It has quoted around 81 very high quality references. The article has been published in a very famous university where our friend Ali Musani belongs. It is the National Jewish Hospital and the University of Colorado School of Medicine. It is the same university where my own son is doing PhD, and James and his colleagues have written a very fine art review article. And their project has been funded by various organizations. As you know, that SARS-CoV-2 is a very complex disease. On one hand, it is asymptomatic, and on the other hand, it is leading to very catastrophic respiratory failure and deaths. So far, it has caused 435 million cases and 6 million deaths in the world. While if you recall, in the epidemic of SARS-CoV-1 in 2001 to 4, that has caused only 8,000 cases and 800 deaths. So what is the difference between the two that SARS-CoV-2 is playing havoc with the human health? We also know that some therapies are effective in early course of the disease, but they become ineffective in critically ill patients, while other treatments, are contraindicated in early disease, but they have been proven to be very effective in late disease. The purpose of this review is to provide a background for understanding how disease progresses in the human lung or pulmonary epithelium, and the prime sites of infection that will be discussed. The contrast is the disease in the conducting airways and the disease in the alveoli or gas exchange portion of the lungs. They have got a distinct cellular composition and they have got different innate responses. I will not spend much time on this slide. This coronavirus. I will only tell you a lot of variants have come up. Very lately in January in Colombia, the Mu variant has come, and by now certain variants of Omicron subvariant of Omicron has also been discovered, I think, around in 47 countries. The characteristic thing about the RNA of this COVID-19 virus is that it is a positive strand RNA. It means when it goes into the host cell, it does not require any modification. It goes to the reticulum and it starts doing its job. So it is little different in that way. I would also like to give you some view which is a very special portion of the coronavirus, which is the spike protein. This is the armament this virus has got, and it has got two portions. One is S1, and which bears receptor binding domain on the top of it, and it has got the S2 portion. The two portions are joined with the fusion peptide. This is the area where a certain proteases work and separate the two components, and the virus RNA enters into the cell. So we will discuss the infection, how it occurs in the conducting airways, like sinonasal passages and lower conducting airways as well, which are almost the same. And the infection in the gas exchange unit or the alveoli is hugely different from what occurs in the conducting airways. You know that when we inhale virus particles, they primarily deposit on our nasal mucosa. The nasal mucosa consists of ciliated columnar cells, goblet cells, and the basal stem cell mainly. These ciliated cells are the primary target because these are the cells that express angiotensin converting enzyme 2 and the transmembrane serine protease TMPRSS2 on their apical surfaces. These are the cells where main viral application occur, and they are released into the lumen. If you see at the host cell, the virus follows two pathways. Either it goes to cell surface, it binds with the angiotensin converting in ACE2, and then these proteases, TMPRSS, SS2, and the other trypsin, it actually cleaves the portion, and the RNA enters into the cytoplasm and then go into endoplasmic reticulum. The other way is the virus binds with the receptor, and then by the mechanism of endocytosis, it goes into the cytoplasm and then into the endosome, where they are processed by the cathepsin and they are released the RNA, and then again this goes to the Golgi apparatus and start manufacturing itself. And the virus which is relieved, they are primed by a special protein which is called furin. I will let you know the importance of the furin in next few slides. As you see that this is a typical mucosa of the sinonasal passages. You see the ciliated cell, you see the mucous gland, and you see the basal cell. You have to remember that the virus is particularly attracted towards the ciliated cell. And particularly, it is not the cilia which is bound to them, rather it is the microvilli on top of it where there are receptors. Once the virus gets into that, it replicates and releases and invades other cells. So in this way, eventually, very late, the interferons are released and other cytokines released, which start destroying these ciliated cells. And along with that, they also destroy the mucous cells. That is why the barrier is lost and these cells are damaged. But the difference is that here the basal cells are not affected. These basal cells are the progenitor, which actually then produce these respiratory epithelium again. That is how nasal mucosa is not permanently damaged. Another feature is of the SARS-CoV-2 virus is that it has somehow developed the ability to dampen or reduce or delay the immune response, or it delays somehow the release of interferon and cytokine response as compared to other infections like influenza. In the research, it has been found that interferon gene expression is markedly lower in patients with severe COVID infection than those with mild disease. There is another thing is that in the nasal, you know that our sinonasal passage is exposed to many microbes, so their immune system is already damped because of these repeated infections. Another feature that has been found out that maybe it is the reduced temperature of the sinonasal airspace which actually contribute to the reduction in the immune response in these cells. Very lately, another article I found that SARS-CoV-2 virus has got a special feature of its receptor binding domain. What it does, it cheats the immune system. If you see on this slide, that most of the time these RBD domains stay in a line position, so they don't expose themselves to the immune system. Only then when they reach on the target, they are activated by furin so that they get erect, and then they are come in touch with the ACE2 receptors and then attach with them and they go into site. So this is how it hides it from the immune system. Possibly this is the reason the early immune system doesn't respond. We know that these infections in nasal passages, they may be asymptomatic, or sometimes they cause local symptoms. The major local symptom, is in certain individuals, we find that they develop anosmia. This anosmia is due to the infection of the epithelial cell of the olfactory bulb. There's a concern whether the virus travels to the central nervous system through the olfactory nerve by retrograde passage. And there's also concern that what is the significance of this anosmia, how long it lasts, and what is the clinical outcome of such cases. Well, therapeutic options, if we consider in the nasal passages, it is very clear that either we should somehow block the RBD or receptor binding domain of the virus by developing some monoclonal antibodies against them so that they're blocked and they're not latched with the ACE2 receptor on the cell. Second option is that this is a site where we can use antivirals like remdesivir or favipiravir or like these. These also are effective on early stage of the disease. It has been found in research that inhaled beta interferon, they can also stimulate the innate immune response. It has been found in phase 2 trial, but we need further trials whether they are really going to be effective in the early disease. We know that systemic corticosteroids in this stage of the disease are not indicated. There might be a role of inhaled steroid, and the research is going on at this aspect of the inhaled steroid. We also know the IgE is especially important in mucosal immunity, and it is highly effective in neutralizing SARS-CoV-2 in the first few weeks after the onset of symptoms, but it is not still used in major studies. If we go down to the nasal passages in the trachea and the tracheobronchial tree, the cells in this airway, the conducting airway that express ACE2 and TMPRSS2 are either ciliated cells or mucus secreting cells and the club cells. Or infection in this bronchi does produce epithelial injury, and in certain cases it severely damages the epithelial surfaces. But these surfaces, as I told you, these are basal cells are not damaged as in nasal passages. They are repaired. The only thing happens that cilia are lost. So when cilia are lost, mucociliary clearance is lost, and the handling with the virus becomes really difficult for the body. Now I will come to the other area of the lung, which is the gas exchange units or the alveoli, and see what happens there. It has been found in the research is basically it is the aspiration of the sinonasal secretion, which is the major source of infection in alveoli, in contrast to the inhalation of the virus by direct respiratory inhalation. Here, infection by that time, when infection reaches the alveoli, the immune system is already primed, and it invites very robust innate immune response, or particularly very severe inflammatory response occurs in the alveoli. And due to this inflammatory response, you see that there's alveolar damage, there's the formation of hyaline membranes, and there even the microvascular injury, and in some cases, there are thrombi in the small and large vessels. When this occurs, the barrier is broken, and there's a flooding of fluid into the alveoli, and pulmonary infiltrate are formed, and it leads to hypoxemia and respiratory failure, and subsequently it can lead to oxygen dependency and ARDS and all that, and eventual very serious morbidity and high mortality. So this is the schematic representation what happens in the alveoli. Here you see there are two types of cells, and pneumocyte type 1 and type 2. Type 2 cells are basically the cells which are affected by the virus. And these are the cells, while the type 1 cells are not affected. These type 2 cells are the cells which produce surfactant. And you know the surfactant layer reduces the pulmonary alveolar tension, and it makes the work of breathing easy for us. And secondly, these cells also act as a progenitor, or they produce other cells when the injury occurs. So when these cells are activated, they release interferon beta and alpha. Then they recruit macrophages, and macrophages release cytokines and interleukin and CXS-CL10, and then they start destroying everything in the alveoli and even the endothelial surface and the vessel. Consequently, you see these cells are damaged, and these are the cells which actually regenerate the cell. But when they are damaged, then it is not possible to regenerate the epithelium successfully. And the consequence of the inflammatory response that I already explained is huge. And this is what we are dealing with when the people with oxygen dependency come to us. So here, how can we deal with that? You know that here, inhibition of the viral application should still be the goal. It does help when you somehow inhibit the viral application. The second objection should be somehow we should preserve the architecture of type 2 cells or their survival. And we should suppress inflammatory response so that it should not destroy the alveoli. And we should also try that we should prevent endothelial injury, which leads to microthrombi, even large thrombi are formed, and somehow we should prevent all that. And all of you know that, and when we treat them, we keep our eyes on this aspect of the disease. As you know that the emergence of dexamethasone has actually changed the outcome of alveolar disease in COVID. And since then, when we started using dexamethasone, the outcome of the disease has really become better. And it can only be found to be useful in hospitalized patients who are on mechanical ventilation or at least supplemental oxygen. It diminishes tissue inflammation, which is actually cause the damage, and it's also been found that it stimulates surfactant production in vivo, which is very important for the health of the alveoli. It also stimulates type 2 pneumocytes in vitro as well. So it has many roles in the alveolar disease. Another compound or compounds that we know are working are anticytokines. These are the monoclonal antibodies that block the IL-6 receptor. You know that this is the marker that very serious inflammatory response is going on, and that's going to damage the alveoli, and the whole outcome depends upon the architecture of the alveoli. So these are used in conditions when we want to stop the storm. So in the treatment of, actually now we know that treatment of COVID-19 depends on the stage of the disease and the cell type that are infected, depending upon whether you're dealing with them in the nasal mucosa or you're dealing with them in alveoli, and the total long-term sequelae of the SARS-CoV-2 infection actually depend how much damage it has caused to the alveolar epithelium. Another thing we need to, there are many unanswered questions that what is the mechanism for the reduced immune response in the nose and bronchi compared with the lower respiratory tract, though we have postulated and I've told you many things that appear to be responsible for that, but the explicit or absolute answer has yet not arrived. Another thing is that at what stages of disease we should enhance or inhibit the immune system. At what stage we should use these sort of drugs. And what treatments can preserve type 2 cell survival and function in the lung and enable them to fully restore the alveolar epithelium after injury. I think these questions are to be answered. A lot of research is coming on. I hope that the COVID is receding. I hope this pandemic will be over soon, or it will not return to the same intensity in the future. Thank you very much for your patient listening.
Okay, thank you very much, Jawad. I think Dr. Sajjad, so thank you for your very well presentation, and now we are open to question, and if there is any question, please do ask. There is a question in the chat box from, first of all, from Dr. Sajjad. Someone has asked about how can we proceed with management in terms of medication. I think he asking about those patients with IPF who have nocturnal hypoxia. So the relation with that, I mean, can nocturnal hypoxemia be improved by some medication apart from oxygen? This is a question.
I think obviously, that's sort of probably a separate discussion. But we all know that currently we have only two medications for UIP, pirfenidone and nintedanib, which can be used for UIP or IPF patients. But obviously, the cohort group which was studied by the meta-analysis was quite varied. And we are seeing a lot of interstitial lung disease. And as Sir Jawad mentioned, that with the COVID, there has been lots of structural changes in the lungs, and we are seeing a lot of patients with post-COVID lung fibrosis. So I think we are coming to a very difficult and challenging times ahead for us as respiratory physicians because of the post-COVID syndromes and post-COVID lung fibrosis, along with the ILD group and with the increase in the survival of our population in Pakistan, and we're seeing lots and lots of patients with UIP and connective tissue disorders. So lung fibrosis is something we are seeing more often than as compared to a few years ago. I think the important message which probably I would like to take home from the meta-analysis is that nocturnal hypoxemia is very common. It's present in about 40% of the population studied in the meta-analysis. We need to identify the way and means of diagnosing them at the right time. And the things which can help in the diagnosis is the presence or absence of pulmonary hypertension, and also the DLCO, which is available in certain centers to know the diffusion coefficient. It can guide us to find out the appropriate group of patients which can benefit from nocturnal oxygen supplemental oxygen at night. And definitely, I think there is a big room to find out the big question that what is really a significant nocturnal hypoxemia. And obviously, we are waiting for other studies to come up to give us an answer. So I think just to summarize, there's no sort of a simple, straightforward treatment, and we need to treat the fibrotic patients, ILD patients as a team with the cardiologist, with the rheumatologist, with the respiratory therapists, with the respiratory physicians, with the chest physiotherapy nurses. So it's a multidisciplinary team approach which has to be applied for dealing these complex patients.
Yes. Yes, Sajjad, I was just wondering that, you very rightly said that, I mean, one of the criteria could be, if we do the respirometry and when carbon monoxide gas transfer and pick up patient from there. Is there any thing we can look at the extent of the disease through the HRCT, and those patients who have, say, moderate to severe disease, we do their overnight pulse oximetry. Obviously, we can't do in everybody that IPF patient, all IPF patient that we see, but at least, the moderate to severe disease on HRCT. Is there anything in the literature about doing that?
Sir, it's a very, very good and valid question. And I think that what was the expectation from the meta-analysis. And some of the studies that looked at the extent of the fibrotic lung disease on the HRCT and tried to figure it out whether there is any linear co-relationship with the nocturnal hypoxemia, with the severity of the lung disease, either on the HRCT or on the lung function test. But interestingly, there wasn't any significant association. So I think coming to your question, probably still we cannot rely on the HRCT or on a simple forced vital capacity test like a spirometry test to identify the group of patients who might benefit from supplemental oxygen. I think from this meta-analysis, we found out that DLC or a transfer factor can guide us. And also, I think the easiest test which everyone has an access to is an echocardiogram. If you do an echocardiogram and there's a pulmonary hypertension on the echocardiogram, I think my personal practice is that we check their blood gases and maybe do their overnight pulse oximetry studies and try to see that what their TST, less than 90% time is. And again, I'm sure that from your experience, you would have found out that by doing these simple basic tests, we can identify the patients who normally benefit from nocturnal supplemental oxygen.
Can we involve Jawad into discussion? Jawad, can you unmute your mic, please?
Yeah.
And Jawad, I was just interested. Okay, fine. I was just interested in, asking you, in general, in Pakistan, the, acceptability of people with, very advanced lung disease with oxygen is very poor. And it's because of, in general, in society, they consider someone receiving oxygen is very bad, something, who is terminal, that kind of attitude. And we have so many patients now, post-COVID patient and IPA patient, and we want them to take part in normal, social events. Like just 2 days ago, a patient wanted to attend a close family member wedding, and she has got IPF, and she is scared that what will people say if I go with oxygen? I said, you can go with oxygen, no problem. But I think in general, I think compared to the Western society, in our Pakistani, the acceptability of oxygen is something considered, a stigma kind of a thing. What do you think, Jawad?
I fully agree. I think it is a very difficult area. A lot of things which are very acceptable for the Western society, somehow they cause stigma to us. And we keep on convincing people, but they say, oh, Dr. Saab, ye machine utha ke jayenge, ye jayenge. They prefer to live with 70% oxygen and with a lot of respiratory difficulty rather than using oxygen, which is now readily available in many forms. But I think they resist. But doctors should still insist them. And I show them certain videos of people walking with oxygen in markets in Europe, and sometimes try to convince them. Though cost is not much high of the oxygen concentrators, they can really buy it. But I think we'll keep on convincing, and it is very difficult area to convince them to use oxygen. I agree with that.
Okay, Jawad, coming to your paper, I think you very nicely highlighted the effect of COVID on cellular level. I think in the beginning of the COVID, we saw so many cases where after resolution of COVID, they kept on complaining dyspnea. And, their CT scan is fine, their physical examination is fine. That patient insists, Dr. Saab, I mean, I feel short of breath. I can't do the activity. We waited for, some time, chand hafte guzarenge, chand mahine guzarenge, but their dyspnea persisted. And, so much so that in some patient, we used to think that it is all psychological and it is all stress. And but after reading those papers, the kind of paper you presented, there is a lot of damage that takes place at cellular level, at alveoli level, and many of those cases were not actually psychological. It is a genuine dyspnea. So, what do you say to that, Jawad?
I think you might recall in the beginning when we came to know that certain people actually, in contrast, were coming to us with a lot of infiltrates and and hypoxia, but they were less symptomatic. And there were also cases which were very hypoxic. I think this damage has occurred and people did not realize. And secondly, I think it is thanks to dexamethasone and then anticytokines that helped us in restricting some damage to these areas, which is very essential. Even now, the people who have damaged their alveoli, and you see them on CT scan, and they desaturate and walking oximetry, we don't know what is going to happen with them. Though I have seen certain people a year ago which were coming with desaturation. Now they have come up with a lot of better oxygenation. I think somehow natural healing is occurring. And whether low dose of steroid or high dose of steroid, whether pirfenidone is working or not, but I think something over years also heals them naturally as well.
जवाब कल की क्लिनिक में मेरे पास एक पेशेंट थी जो कि she had COVID 2 years ago, and 60 years old lady who had COVID 2 years ago, and before that COVID she used to walk quite normally. But we hoped that her condition would improve with the passage of time. She was lost to follow up. अब आई है दोबारा, तो we did an echo and we found severe pulmonary hypertension in her. It was, in fact, an echo, it was 80 millimeters. Oh. And I thought, we must rule out कि thromboembolism तो नहीं हो रहा है उसको. But CT scan we did, CT angiogram, but there was no pulmonary embolism in it. And HRCT के अंदर जो उसके cuts हुए, उसमें कोई ऐसी significant fibrosis नहीं है. Yet she has got pulmonary hypertension. We do not know. I mean, she never had any echo or any test done before 2 years, so we do not know what was underlying. But functional class was quite good. So just wondering that, I mean, there was some damage that took place at a cellular level, which we are unable to pick that up with the present test that we are doing.
I agree. For example, when the damage is restricted and the storm is gone and the epithelium is damaged, then this damage may not be picked up by HRCT. And I wonder whether you have done walking oximetry on her, and how was that?
Yeah, saturation, at breast was 91, and then 6-minute walk test, it dropped to 86, 87. Oh. So mild drop was there.
That indicates that the alveolar surfaces are damaged. And secondly, there might be microthrombi or microemboli, which explains that pulmonary hypertension, I think.
हाँ, मुझे एक स्टडी याद है, एक आई थिंक कैम्ब्रिज में एक ग्रुप ने किया था, and it was just a pilot study on 10 patients who had a normal HRCT, and then he did some special radioisotope study on those 10 patients who had a post-COVID but normal HRCT, and he picked up a significant abnormality at a cellular level through that special scan that he did. I can't recall which isotope he used, but he was able to pick up that significant effect at a cellular level after COVID. So we are going to see, I think, after this COVID pandemic, we as a pulmonologist will be seeing a lot of cases. We are already seeing post-COVID sequelae patient in our clinic, and I think we have still a lot to learn about what COVID has done to our lungs.
That's true. That's true. It has taught us many things.
Right. And let me just check if there are any other questions in the chat box. Let me see. No, I don't think. So, I mean, there is a question that I have is in patient whom we treat with dexamethasone, they get better. They are discharged. I mean, sometime from the medical service, from the infectious disease people, and they stop steroid after 10 days. As recovery trial, they gave dexamethasone for 10 days, 6 milligram for 10 days. But some of these patients, when come back for follow-up, they still have significant abnormality on their chest X-ray as well as on HRCT if we happen to do. And I'm just wondering that, just stopping in those patients dexamethasone in just 10 days time was not a good thing to do, because the inflammation persisted and it led to significant damage when they came to us as a pulmonologist. So what Sajjad, you and Jawad feel about that? Should there be testing at the before stopping steroid? Should we be doing HRCT? That maybe these patients need little longer period, or just recovery trials, so 10 days, so we stop in 10 days.
I think if I answer first, when a 10-day trial is, first of all, it has to be given when it's to be given. Once they come back and I do 6-minute walk test and see if they desaturate. If they desaturate, then I continue with oral steroids and they keep on improving. Very lately, I think a week ago, we read a paper, you might have gone across, that even the low dose steroid, a 10 milligram a day, has been found to be as good as with higher dose steroids in this continuation phase. And so I think those who desaturate must continue oral steroid and maybe later reducing the dose. There's no scientific evidence, but I think the latest paper this is published, it shows that these low dose steroid may be helpful in them.
Yes,
I think so. But to me, as you rightly mentioned, that it's a new disease, it's a novel disease. We are learning almost every day with this disease. And my sort of, from the reading and learning, what I've seen is that I try to figure them out in the different phenotypes. And I'm sure you would have seen that as well. That some people, they show a very good, quick response to the steroids. Then we are seeing a cohort of patients which are sort of lingering on, and as sir mentioned, that you do say 6-minute walk test, you repeat their say X-rays, you repeat their ferritin levels, CRP, D-dimers, and even after 10 days they are sort of either not completely recovered, they're clinically still dropping their SATs. So that's another cohort of patients we are seeing, and in that cohort, what I normally try to do is that I prolong the steroids, just treating them as ground glass opacification with NSIP type of a pattern, and giving them steroids for a few more weeks to reduce the inflammation. Then we are seeing a third cohort of patient with a significant sort of fibrotic lung disease with a little ground glass changes. And in spite of being on steroids for 3-4 weeks, they're still oxygen dependent. And still they are having NYH type 3 or 4. So again, in that group, as we don't have any clear data, but my personal sort of preference and practice is that I carry on with the steroids with the assumption that if we suppress the inflammation further, just like we do with NSIP type of ground glass, lung condition, if you prolong the steroids, that might reduce the inflammation, and try to salvage as much as lungs as we can to improve the functional capacity in future. So I think there is no straightforward answer. I think it depends on the phenotype we are seeing across. We'll see a patient who recovers in 10 days. 10 days steroids are good enough, because we know that diabetes is a very important association with the COVID, and giving them steroids for too long can affect their diabetes control. And I think coming to that dyspnea sort of state, again, I think it depends on the phenotype, because you're giving them steroids, you're giving them antibiotics, they are bedbound, they are hypoxic, there's inflammation going on. And it may not be a structural lung damage, but it could be the physiological damage done to the muscles, done to the thoracic cage, done to the lungs, which affects their functional capacity in the long term. And if we are seeing a patient who is in the middle, then you can give them steroids for a few more weeks. But again, with fibrotic lung disease, in my experience, I have to continue steroids for 3 to 6 months at times, just to see how they get on over the next 3 to 6 months and try to get off the oxygen. And again, I think the last thing I would emphasize is the pulmonary rehabilitation. I'm sure AQH is a big setup. They would have a big, fantastic sort of a pulmonary rehab. But as you know, in UK, in each and every center, we have got rehab centers. And I think a stage comes when it's not a medicine, it's not a drug, it's only pulmonary rehabilitation, which all you need, which tries to control your breathing pattern, your exercises, try to build up your muscles. And that might be the answer to the known COVID syndrome.
Okay, I think in the interest of time, we have crossed the time limit of 1 hour. So in the end, I just want to thank Dr. Sajjad Nasir and Major General Jawad Ansari for sparing their precious time and enlightening us with their excellent article. And in the end, I'm also thankful to BMJ Group as well as to KZ Pharmaceutical for their generous support in organizing this educational activity. We are going to meet again next month, inshallah, the first Tuesday of every month. This activity continue. Thank you, Jawad, once again, and thank you, Sajjad, once again.
My pleasure. My pleasure.
Thank you very much. Thank you.
Okay, Allah Hafiz.
Allah Hafiz.